Arora? Okay, please come. So your topic will be a rare case of direct Carotico-Cavernous fistula with partial involvement of sixth nerve. Please start your talk.
Good afternoon everyone. I am going to present a case of direct carotid cavernous fistula with partial involvement of sixth nerve. My patient is a 20-year-old male with complaints of drooping of right upper eyelid and redness in right eye since 1 month, and he had forward protrusion of right eye since 20 days. He met with a road traffic accident and which led to injury to the head, and he had loss of consciousness and vomiting, and which led to swelling, redness and drooping of right upper eyelid, and 20 days later there was forward protrusion in right eye. He also had double vision on opening his right eye and whooshing noises in the head on his right side. There was history of headache on and off, severe in intensity, involving the frontal region, and there is no history of pain in the eye or variation of protrusion of eye with posture. Past history and general examination, nothing significant, and systemic examination, oculomotor nerve, trochlear, trigeminal and abducens nerves were not intact. And on diffuse light examination, his eyebrow was raised on the right side and there was drooping in the upper eyelid in the right eye. On ocular examination, uncorrected visual acuity in right eye was 6/9, best corrected visual acuity was plain 6/9. Pupillary reactions, pupil was mid-dilated and fixed in right eye. On non-contact tonometry, pressure was 21 mm Hg, and on applanation tonometry it was 24 mm Hg, and there were increased ocular pulsations seen in Myers, and corneal sensations were decreased in all quadrants. In left eye it was into the normal limits. On slit lamp examination of right eye, we can see the conjunctiva is congested and with tortuous vessels coming towards the limbus, and there was mild chemosis present nasally and temporally. Cornea, anterior chamber, iris was normal, and pupil is mid-dilated and fixed. On ocular movement examination, there was limitation in all the gazes in right eye, more towards the levo side. On inspection, in the worm's eye view and Nafziger's view, proptosis was also present in the right eye. On palpation, on retropulsion test, resistance was felt and orbital pulsations were felt. On auscultation, bruit was there. And on gonioscopy of the right eye, columns of blood vessels were seen in Schlemm's canal in nasal and temporal quadrants. MRI of both the orbits was done and there was dilatation of superior ophthalmic vein was seen. Diagnosis of right-sided traumatic direct carotid cavernous fistula was made. Management, first procedure was done, embolization was done in September 23, and after post procedure, these were the photos of which I could get from the patient. And then second procedure was done in October 23 through transfemoral axis. Guider was placed in right internal carotid artery, and runs were revealed remnant CCF with forward flow into superior ophthalmic vein, and venous access into superior ophthalmic vein was obtained via facial vein, and coils were again placed in the vein. Then check runs post coiling revealed complete cessation of flow into superior ophthalmic vein. And this is the post-op photo after the second procedure which I could get from the patient. And concluding, studies have reported an incidence of 0.2% in case of direct CCF in patients with traumatic brain injury and up to 4% with skull-based fractures. Results of embolization for direct CCFs are favorable with successful angiographic closure in up to 93%. And recurrence is rare but more common in younger patients, and it should be suspected in a patient with recurrence of diplopia. And intervention should be done as early as possible in cases of direct carotid cavernous fistula. Thank you.
Thank you, Dr. Kriti. It was a nice presentation. So, what ocular findings did you notice here?
Ma'am, complete ptosis in the right eye, and ocular movements were limited. Then ma'am, pupil was dilated and fixed, and conjunctival congestion, chemosis was there, and ma'am, on applanation tonometry, pressure was raised and I could see increased ocular pulsations in the manner.
So why sixth nerve is affected in a CCF?
It is in the near to the sympathetic chain, sixth nerve is present in the cavernous sinus. So it is most commonly involved. Sixth nerve is most commonly involved in a case of involvement of cavernous sinus.
But in your case, it is
There is
presented.
Yes,
Is
ma'am.
it rare presentation? Ma'am, anything?
But you said in the paper like partial involvement of sixth nerve. But
Yeah.
whatever you featured, I think complete involvement or partial it was.
Sorry, ma'am.
Your
Ma'am,
case is partial involvement of sixth nerve partial or complete?
ma'am, partial.
Partial.
Yes, ma'am.
Okay. What are the main causes? Usually direct, cavernous fistula, CCF causes?
Ma'am, most commonly traumatic cause is there. Then spontaneous can also be there due to any collagen vascular diseases, Ehlers-Danlos syndrome, and any history.
Traumatic or spontaneous?
Yes, ma'am. Traumatic and spontaneous.
And spontaneous one most commonly seen in postmenopausal.
Postmenopausal, yes, ma'am. Females.
That you have to see. Okay. And treatment vision, you have not mentioned anything? Complete
Actually,
recovery, but
the patient was lost to follow-up, so I could just get the photos from him directly.
usually they get 6 normal.
Yes, ma'am.
Okay. Thanks.
Thank
The
you.
results were gratifying. Very good.
Thank you, sir.